Okay, members, today, Wednesday, January 21st, and our time is 1 o'clock here. I call Health, Finance, and Policy to order on the 22nd. Let's get the right dates here, so sorry for that. So January 22nd. We're going to begin this hearing with an announcement here. As a reminder to members and the public, there are to be no signs, outbursts, or clapping. Those in attendance must be seated, and the aisles must be cleared and walkways. If there's something that needs to be accomplished because of a particular situation you may have, communicate that with the sergeant staff. If there are any disputes during the committee business, you will be escorted out of the committee room, and members of the public shall not approach committee members at the table. So also as a reminder, today we run this committee everything through the chair. So if there's questions, our committee administrator, Scorby, Miss Scorby, see I get that right, we'll jot your name down and then I'll call upon you. And same thing with the testifier. So first of all, our main agenda today is discussion with the Minnesota Hospital Associations. As an EMT, I know the importance of hospitals in life situations, and I am very proud to have the hospitals here today. Without them, we would not have the robust healthcare system we have in Minnesota. I do want to remind our hospital members, it's our EMS people who bring you your customers a lot of time, okay? I just want to remind you of that. So the first one on deck is, our first testifier is Rahul Karan. If I'm not correct, please correct me. And he is the president and CEO of the Minnesota Hospital Association. And Mr. Karan, welcome to the committee. Please introduce yourself for the record and proceed with your testimony. Thank you so much for joining us.
Thank you, Mr. Chair, and thank you to all of the members of the committee for having the Minnesota Hospital Association and many of our members here to tell you the state of the hospitals and healthcare organizations that provide patient care across our great state of Minnesota. I will begin and then I will call several of our leaders who have either flown or driven from across the state to talk with you this afternoon. So as I said, and as Mr. Chair said, I'm Rahul Karane. I've been with the Minnesota Hospital Association for over a decade, and I serve as the president and CEO. I am an internist, so I trained in internal medicine. I came to Minnesota 26 years ago, so I have been in healthcare in our state for 26 years, providing patient care, but also serving patients and communities. I began my work in a beautiful lake town called Starbuck, Minnesota, and Mr. Chair was our elected official and lawmaker at that point, and I was the primary care provider there. I worked in the hospital there. I worked with the ambulance there. And I was in Starbuck as a primary care provider for 5 years. The hospital in Starbuck is now closed. And I'm worried about many of our other hospitals across the state of Minnesota. If we look at national numbers over the last many years, we do see many hospitals closing. We have, across the nation, we have tried to maintain our services and prevented as many closures as other states have seen. But I'm worried about the sustainability of what our hospitals are trying to do for our patients and continue to provide access and the broad range of quality services and community benefits that we provide to Minnesotans and that our patients need and have come to expect 24/7 at midnight, holidays, no matter what day it is, we are there. After the hospital in Starbuck closed, I moved to one of the larger hospitals in the Twin Cities, St. John's in Maplewood, and worked there as a primary care provider and as a hospital physician. So in 26 years in healthcare in Minnesota, that is the experience that I bring to you and the perspectives that have shaped, how I think about what is happening in our ecosystem of healthcare, and it is struggling. Minnesota Hospital Association represents all of the hospitals in our state, and we work very hard in order to make the health of Minnesotans better. The Hospital Association is old. We are in our 108th year of providing services to our members, and our mission is to advance the health of individuals and communities through leadership, advocacy, and collaboration on behalf of our hospitals and healthcare systems. We are very proud of the work that we do together, not just in patient care, but also in innovation and making sure that our patients get what they need when they need it. Hospitals, as you know, are one of the largest employers in any community. One of my team members will talk about the incredible amount of community benefit and economic benefit that our not-for-profit hospitals provide across the state. And they are considered a crucial component of any vibrant local community and the local economy. Given that our hospitals are open 24/7, 7 days a week, 365 days a year, and the fact that our emergency rooms and emergency departments do not turn anyone away regardless of their ability to pay or who they are, hospitals are frequently the first call when others in our communities need us. So I sometimes call it the 1-800 hospital number. And again, many of you know this. If the local school needs help, we're there. They call us. If the local nursing home needs us, they call us. If the local group home needs us, public health needs us, or local law enforcement needs us, they call us, and we are there. We are the throbbing heart of any community, open 24/7, with our mission-based, not-for-profit service. Many of the Minnesota's hospitals, and you will hear from many of our leaders today, are really struggling right now. In my 26 years, I've never seen it this bad in our not-for-profit hospital ecosystem. And this is due to a combination of factors. But simply put, our expenses that support our healthcare workforce and our healthcare professionals and other labor costs, as well as supply costs. So what are the supplies? Again, for those of you that may have visited a hospital or unfortunately may have had to come into one of our hospitals, we have expensive supplies. We have to buy pharmaceuticals from large for-profit pharmaceutical companies. We have to buy beds and equipment and technology and other services. And also, as some of the other testifiers will showcase, we are proud to support our workforce, our nurses, our physicians, our social workers, our environmental care professionals, and pay them fairly. In fact, our registered nurse pay is one of the highest in the country here in Minnesota. So we are proud to do that. But between the supply costs and expenses for technology and supplies and the expenses to support our workforce, the expense side of our ledger is growing. And what we get paid or the reimbursement is not at all keeping pace, especially governmental payments from the state's Medicaid program and also the federal Medicare program, and commercial payers are not keeping up with their reimbursement. So that creates a gap, and why you frequently see stories about hospitals across the state losing a lot of money and really being on the brink. Reimbursement for services, particularly services like mental health and others, pay well below the costs of providing those care. And they're getting harder and harder for hospitals to provide, and you'll hear that from some of our leaders that will join me up here. In addition, hospitals are not always the most appropriate place for some of those services. Maybe the patient needs to be in a group home, and maybe they need to be in a specialized mental health care service provider, or maybe they need to be in a nursing home, but they are still stuck in our hospital and boarding in our hospital. And all of those are not reimbursed, so those are adding up, and that is why we are struggling financially right now. And so we are the ultimate safety net, the provider of last resort, and this safety net is fraying. Although our workforce challenges are getting slightly better post-COVID, and as we've testified this last session, we are working 24/7 to recruit and retain our nurses, our providers, and we have seen an improvement in our vacancy rate a little bit with our recruitment and retention efforts. However, there are still a lot of healthcare jobs open, so we need your help, both in our financial gaps, but also with our workforce, not just to take care of patients, us all right now, but for generations to come. Our state hospitals and healthcare systems truly are in peril right now, hanging on for their lives in service of our patients, our communities, and all Minnesotans. We're asking, and I'll start with the bottom line here, we're asking for your help in several key areas: finance and Medicaid and medical assistance, payments, discharge and difficulty to discharge patients and boarding issues, mental health care services, workforce development for generations to come, protecting the 340B program, and quite frankly, avoiding new mandates that usually add costs with little direct benefit to those whom we are privileged to serve, our patients. Thank you again, Mr. Chair and committee members, for giving us the time today. I am joined by many of our leaders from across the state, like I said, so we are going to take you, and I know you all visit your local hospitals. I've talked to many of you. Thank you for taking the time to go and talk and visit the hospital and walk the floors and see what it is like. But right here for the entire, for the committee that we have, we are actually going to take you on a tour of the hospitals across the state and tell you the dire straits that we are in across our entire state and what is happening in Minnesota in our not-for-profit hospitals. Thanks again for this opportunity. First, let's go down south. I will invite Rochelle Schultz from Winona to come up, please.
Thank you. State your name and welcome to the committee. We appreciate you traveling up to St. Paul.
My pleasure. Thank you, Mr. Chair, for the opportunity today. I also want to just state that I'm very pleased that my new state representative, Representative Rapinski, has been selected to serve on the Health Committee. Healthcare and healthcare delivery is critically important to Winona and our regional community. My name is Rochelle Schultz, and I serve as the CEO of Winona Health in Winona, Minnesota, down in the southeast corner. I've been at this hospital for 23 years, and I've been in healthcare leadership for over 35. And quite frankly, we've never seen financial stresses and challenges to the level that we have these last few years post-COVID. We are a community-based independent hospital, and we're struggling, similar to what Rahul just described. We have a 49-bed hospital, long-term care facility, clinics, and other services. This makes us what's called a tweener hospital. We're bigger than the small hospital, smaller than the big hospital. So we are not a critical access hospital. We are what is known as a prospective payment system hospital, or a PPS hospital. That means that Medicare reimburses us at a predetermined fixed amount for patient care based on their diagnosis, rather than based on what the costs of care are for that patient. Things continue to be bad for many, if not most, hospitals and health systems financially across our state. Expenses are up significantly. If we look at labor, it could be 5 to 7% year over year increases that we've been experiencing. A big part of that is the workforce shortages that we face. Pharmaceuticals and drugs are up 12 to 15% year over year, including also supply costs going up in the 10% range, and all of the costs as we go down the list. And we really can't control much of these expenses, and there's nowhere to pass on these costs. So for example, when vendors come to us and say, we're going to renew the contract for a service that we have, and we have to increase our cost to you by 5 or 6 or 7% because our costs are rising, They put that on us, and we have nowhere to pass on those costs. Government payers, including Medicaid, Medicare, and Medicare Advantage, are not reimbursing hospitals for the actual cost of caring for patients, and this gap is continuing to grow. Commercial plans can no longer accept that growing cost shift from the government. It goes over to our employers, and it's not sustainable. Just to give you some examples of this for my organization, when we look at our payer mix, we are 65% Medicare, Medicaid. And this is also the fastest growing enrollments across our county are in Medicare, Medicaid, and Medicare Advantage plans. Commercial plans are actually decreasing in terms of enrollments. We had our worst financial year ever in 2023, losing $17 million. We cut that last year to $12 million, and we have a few more years to go to get to break even, and that's if nothing else changes. And we can continue to figure out how to do this. But in the end, we cannot cut our way out of this financial situation. And just to give you a benchmark, as that government payer increases, for every 1% increase that we have had, that's an additional $1 million loss to our bottom line. To give you, illustrate kind of the situation that this puts our hospital and my board in as a community organization, we took a look when we were looking at cost controls and being able to bring our costs down at all of our services. And we did deep dives in each of them to look at, are there services that we need to cut that we can't sustain or continue to subsidize? One program that we did look at was the dialysis program. We have about 40 patients at any given time in that program. And if you're familiar with dialysis, that is a life-sustaining treatment that people need 3 times a week minimally. We felt like that was a smaller program. It was a bit contained, so we started to pursue that process. I can tell you it was undue hardship on all of those patients because the closest dialysis program that they could go to would be in Rochester or La Crosse, Wisconsin. And I would also say Winona Health had the only 5-star dialysis program in the region. So we pursued, going down that path. We had patients that looked at moving out of the community because they couldn't do the transportation. Transportation cost for a 30-mile transport from Winona to La Crosse was $272 for the treatment, 3 times a week. People couldn't afford that. In the end, really at the 12th hour, a local donor came and spoke to me, and we had a discussion about dialysis and the critical need for our community. And this donor and his wife gave us $3 million to keep that program for 3 more years. We were losing $1 million a year. So I will have the problem come up again, but right now we have some coverage for that particular program. As we talked about any of the services, at the end of the day, everything that we provide in our community is what our community needs. We're not doing extra things. We're doing what they need us to provide. And we do a great job of providing those services. So any service that comes up for discussion is one that's going to hurt our community in the end. We are the only hospital in the county, and with several surrounding counties, we're the only hospital serving that geographic area. We are open 24/7, 365, as hospitals are, and our emergency department is critical for our patients. I think it's really important to understand that also post-COVID, we have regular issues that we never used to have with being able to transfer patients out that need higher level of care. Oftentimes, we are running into where tertiary hospitals in our region are on diversion and can't take patients that need that higher level of care. In the last 2 weeks, I'll give you 2 examples. We had one patient who had a transplant, was critically ill in our ER, and there were 23 facilities that were contacted to take this patient. None of them could take the patient. Our ER doctors, our hospitalists were on the phone with specialists throughout the day to take care of this patient. We called hospitals in Minnesota, Wisconsin, Iowa, and South Dakota. Finally, at the end of the day, we were able to find a bed in Milwaukee. That patient was then transferred to Milwaukee. We had another patient that had to be airlifted to Madison, Wisconsin. And recently, we also had a patient that was boarding for 62 days because we couldn't find a bed for them in the state. So we need the support, we need the payments, we need things that keep our rural hospitals open. This is a critical issue for access for the people who live in greater Minnesota. We think, it's not so far to the next hospital. It is a very far distance when you are critically ill. Additionally, Winona Health currently qualifies for the federal 340B drug discount program, which enables us to purchase some drugs at a discounted price. Those savings are already added into our negative margin. It's not a separate pool of money outside of that. Without the 340B program, our finances would be much worse. 340B is a federal program that helps fill the significant financial gap by providing savings on our outpatient drug purchases. And we use these savings to serve patient needs in our community. These are savings, it's not revenue. The recent state report shows that we had a savings of a little over $3 million in 340B costs, but that is continuing to dwindle. That's probably half of what it started out initially, and even this year as we're looking, it continues to be cut in half due to the restrictions by pharma. I'm truly worried that our rural healthcare delivery is on the brink. Our state's Medicaid program needs to pay our hospitals to help cover our costs. DHS estimates that the Medicaid program is paying only 68 cents on the dollar of costs. To be clear, this is not what's charged. It is what is the cost of care for patients, for inpatient fee-for-service. And this is at 2019 costs. And we all know that inflation has driven cost up exponentially since 2019. And we urgently need the state's financial relief. I know that you're going to be hearing later in this meeting about some of the ideas to address the chronic underpayments by the state Medicaid program. And I think we believe that this opportunity for us, it would be good for all stakeholders, including the state, employers, certainly our patients, and our hospitals. In addition, I would like to ask you to prevent any changes to the 340B program. I certainly appreciate all of the efforts in the last legislation to stop the restrictions for pharma, but I think it's important to understand not all of them are following those restrictions. Drug costs are overwhelming, and we need those discounted prices that are available to qualifying hospitals in order to provide the services that we do. And please know that this program has come under attack by the very profitable pharmaceutical giants, and we are just trying to take care of people in our community. Thank you, Mr. Chair.
Thank you. I do have one question, Mrs. Schultz, if I may. You said a $1 million per, I want to make sure I got this correct, in your hospital, when you see your payer mix increased by 1% on medical assistance government, you see a decrease with your revenue by $1 million. Did I hear that correctly?
Yeah, so it would be all government payers, so that would include Medicare and Medicaid. So yes, it wasn't that long ago, maybe 5-6 years ago, we would have been in the mid 58%, 57%. For every 1% increase, and now we're at 65%, every 1% increase is $1 million loss to our bottom line.
Okay, thank you.
Yes, thank you.
Thank you, Rochelle. So we will go up north now to Crookston, Minnesota, and I will turn it over to Carrie Mikulski.
Thank you. Please state your name and welcome.
Good afternoon, Mr. Chair, and thank you for having us today. My name is Carrie Mikulski, and I'm the President and CEO of Riverview Health in Crookston, Minnesota. We are a 21-bed independent community hospital with critical access hospital designation. The critical access designation is a federal designation used to identify rural hospitals that were deemed so important to the health and safety and infrastructure of rural America that Medicare set up a program to ensure their sustainability. Reimbursement was set at 100% of allowed cost, plus a 1% margin was deemed reasonable for ongoing reinvestment and capital needs. The support of the critical access program has since eroded at the federal level to costs minus 2%, with Congress using sequestration to balance budgets so that even critical access hospitals are now not fully compensated for the care that they provide to Medicare beneficiaries and must subsidize that care along with the care of Medicaid, Minnesota Care, and the uninsured patients. Minnesota has a large designation of critical access hospitals. Of the 140 hospitals in the state of Minnesota, 77 of us have critical access hospital designation. That is the third highest concentration of critical access hospitals in the country. As a group of critical access hospitals, we also qualify for the 340B program, and everything that Rochelle said in her comments would replicate in Crookston in terms of the importance of the program, our ability to acquire specialty drugs and high-cost drugs, and make those affordable for our patients. We also use cost savings from the 340B drug program simply to keep our hospital doors open. In 2020, Crookston replaced its 1957 constructed hospital. We borrowed $54 million in bond financing from Wall Street to finance that project. We planned, we studied, we did stress testing on the cash flow of that project very diligently going into it. We stayed on budget, we stayed on time despite the arisal of the COVID-19 pandemic. We opened that hospital in the midst of the pandemic, and what we didn't predict and what we didn't plan for, of course, was that pandemic and the hyperinflation in our economy that it would set off in terms of workforce disruption, cost escalation in the cost of our labor and workforce, disruption in the world's supply chain that caused drug shortages, supply shortages, and then rapid escalation when we could obtain those supplies. So we planned, we knew that we would bring on an additional $7.5 million in interest expense and depreciation expense to fund that project, much needed for our community. And we knew that we would have 3 to 4 very lean, break-even budgeted years following the opening of our new hospital building. But the pandemic turned that upside down. Rapid inflation turned that upside down. And for the past 3 years, we have lost between $5 to $6 million each year in a negative total margin for our facility. In an operation of our size, that's a negative operating margin of 9 to 10% each year. So we would classify ourselves as a financially distressed hospital. At the risk, certainly of potential closure of a full hospital or services in the future. We are current with our bond payments, but we are not current. We have not been able to keep the bond covenants or the promises that we made to the lenders of our debt. So we promised that we would hold in reserves at least 75 days cash on hand, and that our debt to service ratio, which is just a metric, higher is better, and it just tells us what we are earning from our operations that allows us to cover the amount of debt that we have. And so our bond covenant that we made was that we would generate at least 1.25 times the amount of debt in earnings each year. And in these past years, we have been right about at zero, which means we can cover our debt payments, but at this time, we cannot save for a rainy day. We are spending down cash. At the end of December, we had 52 days cash on hand. Which is a scary situation for any business in America or anywhere, that if cash stopped coming in, we have 52 days of viability to pay our bills. And that's the situation we find ourselves in today. So the relief that we're asking for is really in a situation for Crookston and our community that we need it rapidly, that we need some action to take place. We will do everything with our volunteer governing board and in our operations and management to keep our hospital and our programs open. Our mission is to serve our community like the other 139 hospitals in our state, but we have to make difficult decisions at times. Nearly 2 years ago, or it'll be 2 years in May, we were forced to close our nursing home. And I use the word forced because it was a painful process for our community and for our staff. Anytime that that happens, we, not only is there an impact to care in the community, to the residents and the patients that we serve, but we're the second largest employer in our community. We have over 300 jobs, and it's a great disruption to our local economy as well. When we look at, like Rochelle said, we are analyzing everything in terms of our recovery and our remediation plans during our forbearance period with our bondholders. So we look to other services that we are terribly underfunded in due to high populations of Medicaid using these services. Home care would be right up there. If Riverview is the only home care agency in Polk County and in our region that is willing to accept and treat and care for recipients of Medicaid, elderly waiver, and other government subsidies that are needed. We currently have 87 individuals in our care. If we cannot sustain our business model and care for these individuals in their homes, they are at very high risk to need institutional placement. And then we look to what has happened with the nursing home industry, the loss of beds that have occurred all across the state, and that gets to be rapidly very problematic if we cannot plug these holes in financing. So that's why you'll see as the session is starting, as the session progresses, the unification of all 140 hospitals in our state with a unified voice with our partners at the Minnesota Hospital Association to bring forth solutions that we feel are viable, to bring more funding to the state of Minnesota, and to start to close the financing gap to the state's Medicaid population. Riverview Health has been in existence since 1898, and we have been designated by the IRS as a publicly supported tax-exempt organization since 1943. Last year, it was quite shocking to us that in the legislative session, the value to hospitals in Minnesota was called to question, and whether we were giving enough back to our communities to substantiate or have value to the state as a tax-exempt organization and to be exempt from property tax. So there was a study ordered, and I know that the study will be reported out to you. Riverview was one of the 7 hospitals that was asked to provide extensive data and interview and feedback into the study. Coming from Crookston and seeing our balance sheet and seeing that, on top of our $5 to $6 million losses that we've had over the last 3 fiscal years, we report extensively. We take our tax exemption status seriously. We report our community benefits on Schedule H of the 990 that is required of us. And on top of those losses that I'm talking about, we have an additional $5.5 million a year. About 8% of our gross revenue is given back to the community that we serve in terms of community benefit. So 7.8%. I think that's a lot. I think that we're doing tremendous things. Yes, a chunk of that is the variance between what we get paid to care for the uninsured, the Medicaid, and the Minnesota care population. That accounts for about $3.6 million in our community benefit every year, because the hospital subsidizes the difference between what we are paid and what the cost is to deliver those services. But on top of that, we are very active contributing to the training of the next generation of healthcare workers through hosting work experiences for students of all ages, from grade school, high school students, college students doing their internships. We maintain charity care programs for the uninsured. We provide life-saving and emergency care for all, regardless of their ability to pay. And yet increasingly, we feel targeted and that we're bearing an excessive burden of scrutiny by the state of Minnesota for that tax-exempt status. We feel singled out. I feel singled out. And even within the healthcare sector, it befuddles me a little bit when you look at where balance sheets are strong and where operating margins are positive within the healthcare sector. I naturally go to our not-for-profit commercial insurers in the state of Minnesota. And when I'm answering all of these questions and justifying what we are doing and telling the stories of the services that we do free of charge for our community to promote health and wellness and access to care. And I think, why are they not interviewing our commercially insured not-for-profit health plans and asking what they're doing with their margin? When one of these health plans sells a policy to an individual that hits a bump in the road and can't pay their premium, their insurance coverage is canceled. I don't know that we're asking them where their charity care program is and how many months are they going to carry this individual that has had a loss of income or other life change that has made them unable to pay their monthly health insurance premium. So then what happens? This uninsured patient needs care and they come to one of Minnesota's community hospitals where we maintain a charity care program. So we take that patient in, we give them life-saving care, we treat, we heal, we guide them through the process to apply for our charity care, and then we write that off and we give that care free of charge. There's other players that have to play a part in caring for Minnesota's most frail and most the citizens that have the most need. Our hospitals provide that safety net. We're on the front line. We have the lights on. We train highly qualified staff to be at the ready 24/7. And yet continually we're required to participate in additional studies, provide more data, write more reports to justify our contributions to public health and safety in the state. And just as I just feel that, I think our story tells itself. We do a community health needs assessment. We identify the dire needs of our community, and we tell our story of what we are doing to take action to meet those needs for our patients. I haven't exaggerated today. Riverview's situation is dire. I would welcome any of you to come and visit your community hospital or our community hospital in Crookston, Minnesota. I thank you for listening today. If we can support efforts to leverage more federal funding into our state, we want to be a partner in that. I want to see this legislative session, I would hope that we would have collaboration and partnership with you to strengthen healthcare access and delivery for all Minnesotans versus some of the adversarial tensions that we've had in recent sessions. So I thank you again, Mr. Chair.
Yeah, thank you. I have one question. It's Mikulski? Is that-
Mikulski.
Mikulski, thank you. So I'm familiar a little bit of your situation. My daughter was actually a pharmacist for 2.5 years up at Hugo. So I'm familiar with what was going from the distance. And of course, I'm familiar with the workforce, some of the stuff. In your area right now, what services have you had to, and maybe you have not, but have you had to cut any services because of lack of workforce in your area?
In terms of lack of workforce, certainly that situation is improving. We have had increased wait times for some services due to the inability to hire enough qualified staff to meet the demand. Some of those examples would be speech, physical, and occupational therapy. We've had longer wait times for patients to have initial assessments. And then certainly the lack of workforce, particularly with licensed practical nurses and nursing assistants, played heavily into the negative financial position of our care center and the ultimate decision to close our nursing home. It was heavily reliant on locum labor, traveling staff, et cetera.
Okay, thank you. Any other further questions from other members? Okay, yes, Representative Zalestikar, go ahead.
Thank you, Chair Backer. My question is, with the closing of the nursing home, have you been able to find successful placements within your region for those patients that you're seeking to discharge, so you're not having increased boarding?
So we are
Yes,
having.
go ahead, Ms. McCallesky.
So at the time of closure of our nursing home, we were fortunate that we were not the sole community nursing home. And so the Benedictine Health System had a nursing home in our community. We worked collaboratively to the extent that we could for staff and residents to move to their team. Very quickly after our closure, a nursing home in our county in Erskine, Minnesota closed. And then we had a second closure after that. So beds for hospital discharge have become very tight. As a critical access hospital, we can use swing beds, so we can have non-acute patients on our hospital floor awaiting placement in nursing home, and that has certainly increased. Pre-pandemic, we averaged 1 to less than 1 swing bed patient per day. With staffing availability, we now can comfortably have 5 per day, and that's been consistently, we've had 4 to 5 swing bed patients. So that has about quadrupled, and we have about 10 to 12 inquiries for other acute facilities looking for discharge placement and looking for a swing bed to get acute beds opened up at their hospitals. So a much tighter market.
Okay, thank you. Representative Gilman and also with the testifiers, just address the chair. It just makes it easier for the staff and so forth. So thank you. Representative Gilman.
Thank you, Chair Backer. My question is, currently, so I got the info on the swing beds, how many folks are using those, but how many currently in Crookston are awaiting placement in general, if it's into mental health or other areas? Like, how many do you have that are in the hospital currently that are awaiting placement somewhere else?
I do not know, I don't believe, Mr. Chair, that we have any acute patients that would be appropriate for discharge today in our hospital that are needing placement elsewhere. But it certainly does occur. Most often, the occurrence is a mental health patient that is needing inpatient level of care. And those patients are typically then held in our emergency room and can be there for several days awaiting placement. Because we do have the ability to move a patient from acute to swing bed status, if they would qualify for that, we are able to do that internally too in our organization.
And Mr. Chair, from a hospital association perspective, we actually studied this in partnership with the Department of Human Services. We ourselves studied it for a week. And during that 1 week, this was within the last 2 years, there were about 2,000 patients waiting discharges in our hospitals across the state. And when we added up the uncompensated care burden of these thousands of patients waiting for 1 year, it was almost $500 million.
Okay, thank you. Follow-up, Representative Gilman, or none?
That is great information to get, just so we can understand just processes for our committee here. I think it's really important to hear. What we do here really matters. Thanks.
Thank you. We have next Representative Van Binsbergen. Go ahead.
Thank you, Mr. Chair. My question is regarding your closure of your nursing home. What's the long-term strategy with that facility that it's been closed? Is there a plan? Just out of, I'm curious.
Are you talking about the physical space where
Yes,
the nursing home
yes.
was? Okay.
Yep, go
So
ahead.
physical space where the nursing home was located, about 50% of that space we have repurposed, and we have started a geriatric intensive outpatient mental health program targeted for mostly the Medicare-aged population to help them transition with loss of loved ones, new health diagnoses, change in living situations, and that type of care. As a service to our community, it's a break-even type service, but I mentioned that we have the critical access hospital designation at the beginning. That allows us to recoup about 99% of our costs invested into the program. And so our other mental health providers in our community cannot do that in an outpatient setting and cash flow that. So it has not been a service that's been available to those that have needed it. And so that's been a benefit, a program we were able to bring into our hospital as a critical access hospital to serve our geriatric population in our community that is needing some short-term intensive support to deal with just life changes to improve and accelerate their quality of life.
Thank you. Follow-up?
No, thank you.
Okay, so we will, Representative DePel has a question. That will be our last question for this testifier. Just to keep everybody, we have 5 more testifiers at 10 minutes apiece. That means we'll be done at 22. Just because I know several people have traveled quite a distance, so I want to make sure that everybody gets that chance. So just keep that in mind. Representative DePel.
Thank you, Chair Backer. My question is, if you could state in 3 bullet points what the 3 biggest issues are for cost and the potential way to either save costs or what you believe is the most ideal path to escape that extreme cost burden.
I think cost burden, if we would look at costs that we incur in the hospital setting today that we would feel does not add value to our patients, it would be the burdens that we have primarily driven by the commercial insurance payers around prior authorization and the paperwork and the things that we need to flow to get approval for our patients to have tests and services that they need to continue their medical treatment. That would be number one. That doesn't add value to the care that the patient is receiving. Secondarily to that, we sometimes get the time we spent on the study to defend our nonprofit status and those types of things that don't add direct value for us.
Okay, good question, thank you. And next on deck, and just to keep everybody on track, about 10 minutes per testifier.
Thank you, Mr. Chair.
Because thank you, go ahead.
So we will go up now eastward to 2 Harbors, and I will turn it over to Greg Ruberg.
Of course, introduce yourself and where you're from for the record.
Perfect. Thank you. Good afternoon, Mr. Chair and committee members. My name is Greg Ruberg. I'm the president of Aspirus Lakeview Hospital in 2 Harbors, Minnesota. I'm also the vice president of Aspirus St. Luke's in Duluth, which is a 267-bed PPS hospital, and also the board chair of Wilderness Health, and that's a 9-hospital collaborative serving northeastern Minnesota. So I'll give a perspective kind of from a critical access hospital, a PPS hospital, and then a 9-hospital group trying to remain financially viable and available in those rural communities. I'm a physical therapist by background. I've been working in healthcare leadership for 25 years, and I had the privilege of working with Representative Zalesnikar my first year on the job in 2 Harbors, and a community leader I looked up to, so it's great to see you here today. I'm going to talk about really 2 primary issues impacting our region of northeastern Minnesota. There are many more, but I think those have been covered quite well. The first one is discharge challenges. And when we talk about discharge challenges, Dr. Karani spoke about this a little bit, and so have other speakers. We're seeing a situation primarily in our hospitals where a patient comes to the hospital either by private vehicle, by EMS for care, and once that care has been delivered and they've been stabilized, we look for discharge options. That might be a skilled nursing facility, an assisted living facility, a veteran's home, a group home, et cetera. And oftentimes we just can't discharge those patients. There are no staffed beds available in our community, in the communities next to us, and so we're trying to problem solve to get those patients out. The issue comes in, a lot of times, I'll speak to the skilled nursing facilities, they just don't have the staff to support all of the beds that they've got physical space for. So they will tell us, well, we don't have the staffing, we can't take your patient, check back next week. And then we hear that the next week as well. What ends up happening then in our tertiary hospitals is we board those patients in the hospital, payment source is done, we're providing care for them, But what that does is it ties up a bed that we could be using to support referrals from around the region. So traumas, strokes, surgical patients that need care then are declined out in the region because there are no beds at the tertiary center. So we're working really hard to try to solve that issue, but it continues to get more and more challenging. What's happening in the critical access hospital where I spend most of my time is we will have a patient with stroke, again, a stroke, a heart attack, a trauma come in. We want to transfer that patient to Duluth for a higher level of care, and they say, I'm really sorry, we just don't have a bed. We don't have a staff bed to send that patient. Do the best you can or find other placement. And I think Rochelle spoke to this well. We're calling hospitals across northeastern Minnesota. We're calling the Twin Cities. We're calling Wisconsin. Wherever we can find a bed, we will try to get a patient there. Sometimes we get really lucky and find a critical care bed, let's say in the Twin Cities. Then we call our local EMS and say, we've got a transfer, and they say, we've got one staffed rig for the county, we can't take your patient, and I'll get to that in a second. So the discharge issue is impacting hospitals in the urban areas, the rural areas, all different types of hospitals, and it's a significant challenge. Again, just there aren't enough beds to support this. The other one that we're really challenged with is mental health, and we spoke to this a little bit previously. I kind of group this into two categories. Probably the biggest challenge for us right now is youth, adolescents that are in mental health crisis. They end up in our emergency room for all the right reasons, and we try to find that higher level specialized mental health care anywhere that we can find it in a multi-state area. And oftentimes there just is no bed for an adolescent in mental health crisis. So we're problem solving, we're making deals to say, we'll hold this patient, we'll call you back every hour. Can you do anything that you can to find this patient the appropriate care? Again, sometimes I think we hit the jackpot and find the right bed for the patient at the right time, then we can't get them there. So the transfer issue comes in again. I would say general mental health crises are also a challenge in our emergency room. Patients will show up, we go through the same thing, calling as many sites as we can, trying to find the right care at the right time for that patient, trying to work with the family to get them there. The challenge we have is, especially in our rural community, is when a family can't manage a family member in mental health crisis, or a group home can't manage somebody, or they don't have the staff, they drop them off at the hospital and just say, we can't care for this patient over the weekend, can you help us? And of course we do. We take them in, we provide really good care. The problem is we don't have psychiatric services and all of those other things that patient needs, so that becomes a significant challenge for us. So the discharge delay is the biggest thing I always think about is we're not delivering the patient the optimal level of care in the right setting at the right time. And so we're really doing patients a disservice by boarding them in our ED, which is not the appropriate place for those patients. Again, that backs up our inpatient beds. It backs up our ED with long wait times, and we're always trying to coordinate and work through those challenges. The other piece around the discharge is oftentimes, because I've got a role in both St. Luke's and Lakeview and Two Harbors, we will say if St. Luke's is full and we need to unload a bed, we'll take a patient to our facility and care for them just to open up a bed for somebody in the region to access that. So again, we're always trying to coordinate and kind of level set as best we can, but it's an ongoing challenge. The other issue I want to talk about is EMS challenges, and I know you've all heard about this and you've helped to address it in last session as well. Lake County is the 5th largest county in the state, about 3,000 square miles. We have an ambulance service in Two Harbors and Silver Bay, about a half hour apart. There are more days than you would believe that we have one staffed ambulance for the entire county. So what that means is they're on call or available for 911 calls, which is great. They'll respond to those and bring those patients to our hospital. But we also have patients that arrive to the ER with heart attacks, strokes, trauma, emergency situations. We call the ambulance to say we need to transfer to a tertiary center in Duluth, and they say, I'm sorry, Greg, we can't go. We have one ambulance for the county. We have to stay here for 911. They have the exact same challenges we have. Financial challenges around reimbursement, Medicare, Medicaid, non-reimbursed transfers. They also have workforce challenges, financial strains, all of those things. So we're always working on that issue. And again, I mentioned when we finally do find a bed and we get everything arranged, we can't get the patient there. And we're calling mutual aid to Grand Marais, the Iron Range, the Twin Cities. We're now calling the helicopter and fixed wing to say, we don't have an ambulance. Can you take our patient? And you can imagine what that does to the cost of healthcare when we fly a patient from Two Harbors to the Twin Cities because we don't have an ambulance. Now, we're able to work that out to help support the patient, so that part gets addressed. But the last thing I'll mention around that, I never thought in this role that I would be this directly involved in emergency situations and patient transport. We created what we call an emergent patient transfer process, where the executive director of the ambulance and myself are the kind of the top of the algorithm, where when we can't transfer a patient out, I get a call at 2 in the morning, and say, we've got a critical patient that has to go, can you call the ambulance service and authorize and work with them so they can leave the county to provide life-saving transport for this patient. What that means is we leave the county for 911 calls. There is no ambulance. And so that, you can imagine the challenges that presents. So again, we're always trying to be creative. We try to solve the problem. It's getting more and more difficult, though, when patients need this higher level of care. And we're not giving up. We try everything possible, but it's becoming challenging. So the last thing I'll mention around that is when our ambulance service has one staffed rig or two staffed rigs without a paramedic, we're sending one of our RNs on the floor in the ambulance as the paramedic, which means we don't have enough nurses on the floor, which means we call nurses in, or our nurse manager or director become our staff nurse, which again, we do, but it's becoming more and more frequent that we have to address that. So what I would ask of all of you, I thank you for your time to listen, and I know we're working closely with our representatives to try to solve these issues, but we really need to fix the funding mechanism around Medicaid for hospitals to help with boarding and transfers and discharges, but also our local ambulance services. So thank you, Mr. Chair and committee members.
Thank you. Any questions? Let's move on.
Thank you.
Greg. Okay, we will move a little bit south to Cloquet. So Cloquet, and I will call up Rick Brewer.
Mr. Brewer, please introduce yourself and begin
Thank-
your testimony. Thank you.
Thank you, Mr. Chair. Appreciate the time today. My name is Rick Brewer. I'm the CEO of Community Memorial Hospital in Cloquet, Minnesota. I've served Cloquet for over 25 years, and I've spent over 34 years in healthcare leadership. Our hospital is a critical access hospital serving residents of Carleton County and the surrounding areas. We are deeply proud of our role in providing care for our community, despite the mounting challenges being faced by rural healthcare providers. I'm sorry, I will try to stay on script. I've given over half my life to healthcare, over half my life, including toddlerhood on up. It is hard not to become emotional about seeing the state of healthcare today. As Rahul began talking about, we are always on, no matter what. If a national health information exchange breaks, basically, we just keep on going and figuring out how to operate healthcare without worrying about when we're going to get paid for that. When a hurricane wipes out our largest supplier of IV fluids, we figure out how to keep delivering care. When a pandemic comes, we were ground zero. And many of us on the front lines and those of us supporting them have been forever scarred by that experience. That was unlike anyone, I would argue, in any other industry experienced. We just kept on going, and we keep on going, and it's gotten very difficult now. So I would like to frame my talk around the concept of healthcare as an ecosystem. Again, as Rahul, you used that term earlier. When pressure is put on any part of an ecosystem, it stresses every other part. So many hospitals in rural communities are among the largest employers in an area, providing a very real economic engine. But beyond that, they may manage clinics, nursing homes, home care, hospice, EMS, and other important local programming. And so when any of those service lines are stressed, it affects us all. Well, I'm here to tell you virtually every aspect of the healthcare industry is under stress right now. I've never seen anything like it in my entire career. I would like to share a couple of stories that highlight these challenges. I'm going to start with labor and delivery services. Like so many rural hospitals, Community Memorial is struggling to maintain OB services, and we fear that facilities like ours may join the maternity care deserts that are growing across the state and across the country. Limited staffing, particularly for specialized OB nurses and physicians, compounded by declining reimbursement, is forcing hospitals big and small to make impossible decisions, leading to mothers in our communities to travel long distance to deliver their babies, creating risks for them and their newborns. Studies that have been performed by physicians from our own University of Minnesota have shown that all else being equal, the farther that mothers have to go for prenatal and to deliver their babies results in worse outcomes. So this has very real risks for moms and babies. This is an unacceptable reality, but it's the direct result of a healthcare system that leaves rural providers without the resources they need to offer essential services. Now, I will tell you, our commitment to rural obstetrics is very strong. Over the last several years, we've established an OB simulation training program. Our goals are multifactorial. We want to ensure that every rural hospital is able to handle and be prepared for any obstetrical emergency situation that comes through their doors. This was always important, but new CMS regulations actually raise the bar for all of us. And so this is something where we can help everyone, because whether you're delivering babies at your hospital or not officially, babies are still going to be born there when they decide to be born there. Secondly, we want to train paramedics and others in the field in the latest basic obstetrical techniques. We also want to partner with medical and nursing schools across the state to make sure that students, as they're going through their training, get enough exposure and experience at the table so that when they come out, they can work in rural settings where they're not going to have as much support around them, and they need to be able to handle whatever comes in front of them. And then finally, and most importantly, we want to be able to offer training and support to those rural birthing hospitals where we have a program that can put in front of them almost every possible medical and surgical obstetrical scenario they might face. And in some cases, this might be the lifeline that can help preserve an OB program in that rural community. We take this very seriously. Now, while we've received significant technical and financial assistance for this program from national and state resources like the Minnesota Office of Rural Health and Primary Care, we donate many hours, space, and a lot of other resources to maintain this program. We do that out of a commitment to rural OB, but we see the challenges in maintaining our own program. Mental health is another area of deep concern. Our emergency department has become a default holding area for individuals experiencing mental health crises. Far too often, patients, including children and adolescents, are boarded in our hospital for days, weeks, and even longer, because there are no appropriate mental health treatment facilities or community resources available. This creates immense strain on patients, families, and our staff who are treating these patients in settings that are not appropriate for long-term mental health care. The lack of capacity across the state for inpatient mental health care and the shortage of community-based services are leaving rural hospitals like ours to fill a gap that we cannot sustainably support. I want to briefly address the importance of the 340B drug pricing program to hospitals like ours. Others have made comments about that. I want to reiterate, it offers hospitals like ours the opportunity to purchase medications at a discount, thus reducing that expense exposure and burden that we're seeing, and we can pour those savings back into the care that we deliver. This program is under threat by the pharmaceutical industry, looking to not pass along those savings to these nonprofit hospitals, and I'd urge you to do your part in helping us protect access to that. Finally, as Greg talked about a little bit, our EMS services are in real trouble. The legislature provided some relief in the last session, but it was a fraction of what was requested and necessary. I'm actually a part of a statewide work group looking at how the whole industry can innovate, better utilize technology, and address their workforce challenges. But EMS needs better funding. Again, healthcare is an ecosystem, and rural healthcare is incredibly fragile right now. We are all working on innovation, collaboration, partnership, efficiency, constantly trying to do more with less, but at some point there comes a tipping point, and I'm worried we're at that tipping point. It is assumed hospitals won't close, and it's assumed EMS won't shut down, and it's assumed that nursing homes and others will always be there, but that is just not the fact. We need strong support from policymakers and state agencies to address these systemic issues. The sustainability of rural health care is at a breaking point. Rural hospitals, nursing homes, and others are more than just providers of care. They are economic anchors and lifelines for their communities. I urge this committee to prioritize rural health care and work with us to find solutions that allow us to continue fulfilling our mission to care for Minnesotans in need. It's what I've given my life to. It's all I really care about. Thank you.
Thank you so much. Any questions for members before we go to the next testifier? Thank you for sharing that. Our next testifier looks like to be Kelly Hagan.
Yes, Mr. Chair. So as Kelly comes up, given the critical importance of our frontline care teams and our nurses on those care teams, we have one of our nursing leaders from International Falls here. So Kelly.
Yes, please state your name, where you're from, and you just had a short jot down from the International Falls, just a hip and hop. So go ahead.
Thank you, Mr. Chair. Thank you, committee. Good afternoon. My name is Kelly Hagan. I've been a registered nurse for more than 40 years and a nurse leader for more than 25 of those years. I am now the Chief Nursing Officer up at Rainy Lake Medical Center, and as you noted, International Falls, so fairly remote up there on the northern front. I am proud to serve our community as an independent rural health care organization. Our mission is to provide accessible, high-quality health care to all of our residents and all of our surrounding communities. We are a 25-bed critical access hospital with 220 employees. Our average payroll every 2 weeks is about $630,000, which does not include contributions to 401Ks, retirement plans, and matching tax contributions. And this number continues to grow. Some businesses and services are high-tech and focused on focusing their expenditures on equipment and technology. Other business and services are high-touch requirements, expensing mostly their expenses on labor. Hospitals are one of the few services that provide both high-tech and high-touch, leading us to spend a lot of money on both labor, supplies, equipment, and technology. This past year, hospitals saw labor costs increasing on an average of more than 6%. Some hospitals experienced on average more than 18%. We know that this had to be done as our registered nurses are in high demand, as are other healthcare professionals. The supply has not kept up with the need across our state. Many of our nurses prefer to work in a hospital setting. The work is very rewarding, and the pay is often better than in other care settings. Minnesota has consistently paid their RNs in the country and higher. Healthcarejob.org recently ranked Minnesota as #1 in the country for nurse pay when adjusted for cost of living. What has changed is the hospitals are working hard to accommodate desires of our working force. Primarily our younger nurses, and some more experienced, want to have more of a work-life balance. To keep our workforce strong, many hospitals are now offering full benefits at 24 hours a week of work. That's 2 12-hour shifts. The latest MHA workforce report showed that 57% of nurses are now opting to work part-time. Most hospitals have very few nurses working full-time or 40 hours per week. Nationwide, demographics show we will need more caregivers, not just nurses, but many categories of healthcare professionals, because aging populations simply need more healthcare services. And this is at a time of an overall shrinking workforce. To continue to prioritize our most important commodity, our patients, and to provide high-quality, safe care, we need the legislature to avoid passing mandates that only serve to reduce access to care. The legislature can take actions to help with workforce challenges, including loan forgiveness for healthcare professionals, upfront scholarships, grants for mental health programming and for healthcare workers, and improving the efficiency of our health licensing boards. We are supportive of a bill being authored by Representative Zelez Nakar, which would extend the 60-day temporary RN permit to 90 days. Last year, the legislature adopted 7 different interstate compacts for healthcare professionals, such as physical therapists, physician assistants, occupational therapists, audiologists, and social workers, and I do believe there are more. Unfortunately, missing from the list was the nurse licensure compact. I also testified on that last year. The nurse licensure compact has now been passed in 39 states. The importance of the compact licensure allows needed resources to be available more timely when needed. I want to close by providing an update on some of the very important work that we are doing. We're focusing and have embraced the new workplace violence safety measures that were passed by the legislature in the 2023 session. Minnesota hospitals have submitted their workplace violence action plans to the Minnesota Department of Health. Those were due by December 31st of 2024. We are taking to heart and working in collaboration with our direct care employees to implement and operationalize that new law. It is important work that is ongoing. Our staff will be trained and supported and kept safe by our workplace violence focus. Thank you for allowing me to provide this information to you, and I will pass it over for questions.
Members, any questions for Ms. Hagan? Go ahead, Representative Zinliska-Card.
Thank you, Chair Backer, and thank you, everyone, for your heartfelt testimony. It's tragic and alarming, and grateful to see Greater Minnesota here at the table. The workplace violence piece, I would like your perspective. If there was adequate inpatient beds for adults and geriatrics that are having behavior, situational outbursts, or pediatric beds. We increased 10 pediatric beds in the last biennium. If there were more beds available to address mental health, do you feel that that would have an impact on workplace violence?
Go ahead, Ms. Hagan.
Thank you. I do believe that if there were more beds available, it certainly would help to impact the length of time that we spend caring for those patients in settings where they're not receiving the type of care that they need. So yes, absolutely. If we could move those patients into the correct setting more quickly, we would see a decrease in that violence. However, in the emergency department, we see an increasing number of patients bringing that violent behavior. And so anything that we can do to move patients to the right setting, getting the right care, right medications, et cetera, certainly would help that, absolutely.
Okay. Follow-up? Okay, none. My question for you, Ms. Hagan, is, first of all, you said International Falls 26 beds, correct? How many beds does your facility?
25 critical.
25, 26, okay, cool. Right now, how many times a year do you reach full capacity?
We rarely reach full capacity as we're not staffed to reach full capacity much of the time.
Okay.
We maximize out for staffing pattern at about 14 beds. We can expand if we're able to access additional staff.
Okay, thank you. And just with you so close to Canada, how does that affect the care? I'm assuming you have some Canadians that come down to your facility. How does that affect staffing, care, just on that there, please?
We do have Canadians that access care in International Falls, primarily for services that are booked beyond a time that the patient is willing to wait. So certain services they come down for. It impacts us just when we have an increased number of folks to serve. Obviously, we have to accommodate those patients, but typically we're able to do that. We see certain services that are not provided in Canada. Sometimes it's a wait, and sometimes it's something that's not provided, and so we ensure that we have resources in place to care for those patients. We're also working with a consortium, a cross-borders consortium, to determine what more we can do to help each other, especially in an emergency situation. Previous testifiers have talked about OB services. We do not offer OB services, although we're trained in precipitous delivery. However, our partners across the border, which is just a few moments away, are. However, accessing that care is very difficult based on regulations, et cetera. So we're working together to find ways so that we can serve our community more intently.
Good. If you don't, thank you. What would be one or two services that you see our friends to the north come down to your hospital for?
CT services, radiology procedures, circumcisions.
Okay, good. Thank you.
You're very welcome. Thank you.
Okay, go ahead. Next testifier.
Thank you, Mr. Chair. So I will call up, thank you, Kali. I'll call up one of our leaders at the Minnesota Hospital Association, Joe Schindler, who has been with the Hospital Association for 38 years.
Okay, so you're a new kid on the block, it sounds like. Okay, so please state your name and organization, and thank you.
Mr. Chair and committee, my name is Joe Schindler, and I am the Vice President of Finance Policy at the Minnesota Hospital Association. 38 years, seems like it just started yesterday, but I've been tracking hospital finances for a very long time, and obviously, as you've heard from our speakers today and from what I have seen as well, this is the most fragile circumstances I have seen. Last year, we had a survey that demonstrated that over half of our hospitals were losing money. That's improved just a little bit, but really what we have to think about today is Minnesota's future depends on a healthy, thriving population and a healthcare system that works for everyone. Yet today, the very foundation of our state's healthcare system, access to care for every Minnesotan, is at risk. For decades, Minnesota's not-for-profit hospitals have been the safety net that ensures every Minnesotan, no matter their income, their insurance, their location, needs get met. Today, though, the safety net is fraying, and currently more than half of Minnesotans are on a government-sponsored program, whether that be Medicare, the Medicare program, or the Medicaid program. And when those programs fail to pay the true cost of care, that affects everybody. And one good example is the Medicaid program, the fee-for-service program for inpatient services administered by the Department of Human Services, has a document payment payment to cost ratio of 68 cents on the dollar. And this is calculated by the state's own consultants that do the work of rebasing every 2 years. So, when government payers chronically underpay hospitals for care, costs don't disappear, they get shifted onto Minnesota families, businesses through higher insurance premiums, co-payments, and out-of-pocket costs. This means working Minnesotans and their employers end up bearing the burden of government underpayment. We sometimes refer to it as a hidden cost or a hidden tax. Through increased commercial insurance rates, making health coverage more expensive for everyone. Small businesses particularly feel this squeeze as they struggle to provide competitive benefits while managing high premium costs. This chronic underfunding has created an unsustainable system. You've likely seen the news headlines, and you've heard today that hospitals have been forced to cut their labor and delivery services, close nursing homes. Everything short of closing a hospital has been tested. So we stand here today asking legislators to take action. And as I mentioned, today you've heard from leaders across the state, and despite our ongoing attempts at the MHA to ask government to pay their bills, we have had difficulty getting our pleas heard, in part because our hospitals have been so resilient in finding a way to balance the books. Well, the day has come whereby Medicaid funding is causing widening holes in the safety net. So, we come to you today with a solution, thankfully. We don't want to just complain. So today, MHA's 140 hospitals across the state are proposing some bold action to address the shortfalls caused by chronic underfunding in the Medicaid program. It's called a Directed Payments Program. We sometimes refer to it shorthand as DPP. This funding neutral program would ensure hospitals are reimbursed closer to the actual cost of care they provide to Medicaid patients, stabilizing the financing and protecting access to care for all Minnesotans. Directed payment programs are proven, federally approved arrangements that 40 other states have already adopted to ensure adequate funding for their own Medicaid programs, which involves no general fund spending. Underscore, no general fund spending. A directed payment program would help close the Medicaid underpayment shortfall while ensuring every Minnesotan, no matter their location, their insurance status, has access to services they need. Now, the mechanics of the statewide directed payments program are pretty straightforward. Hospitals would be assessed a quarterly assessment through a federally approved program for both their inpatient and outpatient services. The funds would be forwarded to the state Department of Human Services, for example, who would in turn demonstrate that is the state share of the Medicaid funding to draw down the federal funding share of the Medicaid funding. And then the next step would be to bring back those dollars to Minnesota and then pay those out in the form of supplemental payments to quarterly supplemental payments through the managed care system or prepaid medical assistance program. This is not a new or untested idea. Directed payment programs have been successful, as I mentioned, in 40 other states. And now it's Minnesota's turn, and we need legislators to act. And we will be forwarding a bill probably within the next week or so. Minnesota's future depends on access to care for all, yet it is slipping away. So without action, communities would lose their lifelines. Rural and underserved areas would risk losing hospitals that provide essential services like emergency care, labor and delivery, and behavioral health initiatives. Patients would face growing barriers, access to care. Families and employers would shoulder higher costs because of this cost shift or hidden tax that's been around for many, many years, and the Minnesota healthcare model would collapse. The nonprofit system that reinvests every dollar into patients and communities, not to shareholders, cannot survive without a sustained funding mechanism in the Medicaid program. So this isn't just a healthcare problem, it's a crisis that threatens the health, well-being, and economic future of our state. Thank you, Mr. Chair.
Thank you. Questions from members? Representative Zalisagard, go ahead, please.
Thank you, Chair Backer. My question is, with 40 other states that have done this DPP program, can you explain why Minnesota hasn't went this route in past years?
Go ahead.
Mr. Chair and committee members, the directed payments program has grown probably over the last 6 or 7 years because of a federal definition change, and that was that in Medicaid managed care, you can pay up to what the average commercial rate would be. So that's what they call the upper payment limit. So for that reason, many states have said, oh, okay, well, we should leverage money to get that. The problem has been that most state legislatures do not have the money, the general funds, to put up that state share, and that's what's driven many states to go to this assessment program by the hospitals to then draw down that federal share. Yeah, we're a little bit behind, but we need to catch up.
Thank you. My question to you is, on the average with this program, what percentage payment increase would we see for example, the hospitals that were in front of us today? Are we talking about a 10%, 20%?
Mr. Chair, it is probably north of that. It would range depending on hospital because you have a broad-based assessment that is then paid out through the Medicaid program. So some hospitals have lower Medicaid rates and others have higher. All that being said, it would range anywhere from, I'll just give you rough numbers of 50% increase to well over 100% increase in reimbursements. Would that close or completely close the funding gap below cost? No. It's over $1 billion now, but it would get us much closer.
Okay. So what, thank you. Because obviously it's important to us on this side of the aisle with the critical access all hospitals, but specifically in greater Minnesota. What would be a drawback of this program?
Mr. Chair, I think one of the biggest drawbacks that we're concerned about is, number one, can the Department of Human Service get this administered in a fair and competent way so that when we put up the assessment, that money drawdown comes fairly quickly afterwards? We can't afford to sit around and wait for money to come back. It's got to be administered very expeditiously so that, because we're using precious hospital resources to fund the state share in this kind of a scenario.
My last question is I know the idea is, lack of a better example, hospitals put in so much and they get more back from the federal government. What's that dollar amount that would be put in from our 140 hospitals? Any idea on that?
Yeah, Mr. Chair and committee, we've done some modeling with a nationally recognized firm that actually Department of Human Services has also worked with. The funding share from hospitals would be approximately $800 million, and that would draw down $1 billion in federal share funding.
Okay,
So that's kind of the math.
good, thank you. Other questions, Representative Schumacher, go ahead.
Thank you, Mr. Chair, and to the testifier, where does the 800 million come from?
Mr. Chair and committee representative, the 800 million would be through an assessment on hospitals. So it would be the hospitals putting up the state share.
Follow-up?
Chair, yeah, so where are they going to be able to afford the assessment?
Go ahead.
Yeah, Mr. Chair, it'll be difficult. I mean, hospital finances are tight. This is why I mentioned just a minute ago. It relies on the state performing their piece of this function to be able to get that federal share back. Can we put up the cash? Yes, we'll do everything we can because that funding is a lifeline. So I would say that, yes, if hospitals have difficulty, we'll work with them, but it's really the mechanism that's used around the country to fund this kind of a program.
Okay, thank you, Mr. Chair.
Yep. So you just mentioned, and Representative Schumacher brought up a good question. Of those 40 states that are doing it right now, how many of those 40 states that the hospitals, the industry itself puts up the front-end funds?
Mr. Chair and committee, I don't have the exact number. It's most of them.
Okay.
So, yeah.
That's good. Okay. Okay, thank you, members. Testifier, and we have, I guess we say the best for the last, I don't know.
Thank you, Joe. Mr. Chair, I will invite up Mary Krinky, who I think all of you know, so.
State your name. I see there's two. We have two. This is so 2 for 1.
I'm just the tech guy.
Oh, okay, you're the tech guy. Okay, so go ahead, state your name and who you're with, and
Great.
thank you.
Thank you. Mr. Chairman and members of the committee, for the record, my name is Mary Krinky, and I'm with the Minnesota Hospital Association. And this is my colleague, Danny Ackeret, and we are the two lobbyists who are lucky enough to get to represent the Minnesota Hospital Association here at the Capitol. And you'll see us at all the committee hearings. So I just want to first thank Chairman Backer for this opportunity and for you all to listen so intently to our members. And as you could tell, they're very passionate and very concerned about what they're seeing right now. And I just want to thank you all for listening, asking questions, and paying attention. And thank you, Chair Backer. Really appreciate it very much. I'm going to just walk through some slides very quickly. Slide presentations are so boring after you've heard so much passion, but I wanted you all to have a copy of some of the numbers that were presented today so that you would have it as a handout with you. And I'm not going to go through all of these, but I want to start out with a map of Minnesota and where we have the hospitals located. So this is just a map of the state. All the dots are there. It shows the critical access hospitals as well as the PPS hospitals. As has been mentioned by several speakers, we have 140 hospitals that are members of the Minnesota Hospital Association. We have 77 critical access hospitals. We are the third highest in the country with the number of small rural critical access hospitals. We have 54 PPS hospitals. There are 7 hospitals that are owned and operated by the state of Minnesota. These are the community behavioral health hospitals as well as the Anoka Metro Regional Treatment Center. We engage with our state hospitals. They are members of the Hospital Association, and we work in tandem very closely with the Anoka Metro Regional Treatment Center. We have 2 veterans hospitals. There are 34 independent hospitals that are not part of a healthcare system. We have 19 district, county, and city-owned hospitals, and a lot of people sort of forget that we still have some government-owned hospitals. We have 109 hospitals that are located in rural Minnesota. And I just want to say how lucky we are in Minnesota that we have the tradition of nonprofit healthcare delivery. I just Googled today the profit margins at HCA and Tenet for-profit health systems around the country. One of them had an operating margin of 20%. So if hospitals are fortunate enough in Minnesota to have a positive margin, if they're fortunate enough, they plow it right back into the services in their communities. We have no shareholders, we have no stakeholders that we give dividends checks to. Our resources go back into serving our communities. I also just want to share a little bit about hospitals being an economic driver. Hospitals have a very high, what is called a multiplier impact in a community. We employ a lot of people, we buy a lot of services, we buy food, we buy linens, we buy drugs. So a lot of the things that we buy in a community are plowed back in. So there is a big multiplier effect for hospitals. We can substantiate there are about 380,000 jobs that are tied to hospitals or the vendors that we utilize. So it's a great economic engine for our state. I do want to turn now to, as you've heard, about the margins that hospitals are seeing. And historically, hospitals were usually around 2, 3, 4% margins. And we have seen a decline that really started in 2015 with the hospital operating margins dropping. As we heard today, what happened with COVID, the bottom fell out. We had to spend a heck of a lot more on workforce and labor costs, as well as supply costs. And I would say that 2023 was the low point, where we had, as has been mentioned, more than half of our hospitals with losing operating margins. I do think the numbers are slightly better for 2024. We're still getting those numbers in. I am hoping, knocking on wood, that the lowest point was 2023. What are some of the negative drivers in this? And it's been mentioned several times today, but I do want to clarify one point that I think is important. Mr. Schindler, my colleague, mentioned that half of our state's population are either on Medicaid or Medicare. But for hospitals, it's about 64% of our patients. And that's because elderly people on Medicare are the ones that use hospital services. It only makes sense, but I just want to point that discrepancy out. Half of our residents are on a government healthcare program, but for hospitals, it's about 64% of our patients. Medicare pays approximately 20% below the cost. Medicaid pays approximately 27% below the cost. You heard Mr. Schindler say today, and I just want to correct one little thing. Joe said that the inpatient fee-for-service rate was 68% below the cost of care, below the costs. He did not mention that was 2019 costs. So that estimate by the Department of Human Services was on a base year of 2019. So think about what has changed in the last 5 years in costs since 2019. We have a math problem. Okay, our revenues are growing because people are coming into the hospital, but the problem is our labor costs and our supply costs are growing at a faster rate. I'm not going to spend a lot of time talking about the discharge challenges, but I do want to mention a couple reasons why hospitals are in financial distress. Medicare and Medicaid underpayments, which has been addressed very well today, uncompensated care and the discharge barriers, and services that reimburse below cost. We have expense realities, and I really appreciated what Rochelle Schultz said today, our first testifier. We don't dictate what our suppliers tell us the prices are. And we are in a position where we have to pay for those supplies for our patients. We don't get to really negotiate what we're paying for drugs, electronic health records, a lot of our supplies and technology. There are things we have to buy. Those prices are fairly set. So we have workforce challenges with, and I do have a couple slides on workforce, but we've had to pay wage hikes, which are deserved. As our nurse testifier today, Kelly Hagan, said, Minnesota hospitals are proud of the fact that we pay nurses the best in the country. But that has some realities for us, and it's just part of the finances that we have. but we've had to pay premium pay, we pay agency costs sometimes when we can't find the workforce that we need. Inflation, as has been mentioned, with pharmaceuticals, high tech, and equipment. And the other reality of expenses that I want to mention, and I know a couple people did talk about EMS, our emergency departments, we do have EMTALA, it's the Emergency Medical Treatment and Active Labor Act. We take care of anyone who shows up regardless of their ability to pay. And an emergency room is open 24 hours a day, 7 days a week, 365 days a year. We're busy right now. We're full. We have flu, we have COVID, we have RSV, neurovirus. If you have to take any of loved ones to the hospitals right now, the emergency rooms are full. I want to mention two underlying kind of principles of healthcare financing that have not been talked about up front a lot. One is cost shifting. For years, hospitals cost shifted underpayments in Medicaid and Medicare. The problem is that's getting harder and harder to do now with fewer people on commercial insurance. The other philosophy of sort of hospital financing is cross-subsidization. We used to take money from some services where we had a positive margin, and then we were able to plow that resource into hospitals that we lost money on, like mental health or OB. And so what's happened now is that many of those services have now been pulled out of the hospital setting. And I want to be clear, this is not necessarily bad for patients, but you will see all over the state lovely ambulatory surgical centers. You'll see cancer centers. You'll see diagnostic imaging centers. These are not bad. I want to be clear. We partner with a lot of them. They provide good services. But those services used to be provided in the hospital setting. And I can tell you, those are the services that have positive margins. So what has been left for the hospitals are the services that don't have positive margins, which is one of the reasons we have to act now to do this directed payment program. I don't really want to talk about the hospital discharge delays. We've had a lot of discussion on that today already, but I do want to pinpoint some of the dollars because it's not a small problem. We did a survey of our members. The numbers were pretty high. We calculated that we were not getting paid for any of these days in the hospital. So it's a combination of folks who need to be discharged as well as boarding in the emergency room. And sadly, many of these boarders in the emergency room are children. And we're not getting paid by the counties or the state. And that totaled up to be about $487 million last year for those expenses. I do want to spend closing comments, and I know we're about out of time, Mr. Chairman, on the workforce issues. And as you all can see, the gray is where there are employees available, people available. This is spikes in unemployment. And as you can see, that was 2009, that big gray spike, that was during a recession. Then you can see what happened at the beginning of COVID in 2020. There was a big gray spike. Then what's happened as the economy has gotten better, the number of our vacancies increase. So it's kind of counterintuitive. It's easier for hospitals to hire when the economy is bad. And that sounds terrible, but when the economy's good, people have a lot of other options and places that they can work. So I do want to share one comment on workforce, and then we'll close it out. There are some concerns with workforce right now. More and more of our young people are wanting to work part-time, and baby boomers like me are going to retire soon. You're supposed to laugh
Never
at that.
retire.
And so what's going to happen is we're going to have more people retiring and less people in the workforce. And when the economy is soft, it's easier for hospitals to find workers. And when the economy is strong, the competition for food, environmental services, and others is strong. There are fewer students right now at our MNSCU and university campuses, so we're training fewer healthcare workers. This is a challenge that we're going to have, as well as others in the healthcare workforce. I want to close out with what was mentioned about the office, about our community benefit. Last year, the legislature directed the Office of Legislative Auditors to look at hospital community benefit. It was one of the selected topics. Every year, the legislature picks a half a dozen topics to look at. And they did interview several of our members, and we submitted data to them. I am proud of the work our hospitals are doing in the community benefits. So I am anxiously waiting this report to see how it is presented. But I wanted to share with you, as we close this out today, the numbers from our most recent report, and they are staggering. Hospitals, for the first time, uncompensated care has grown to over $1 billion. Medicaid underfunding has grown to over $1 billion. Medicare underfunding has grown to over $1 billion. Hospitals are now plowing back into their communities. This includes research. This includes training for medical education. We are now contributing to Minnesota $6.2 billion in overall community benefits. And I think our hospitals have a great story to tell, and I look forward to working with all of you all as you all have questions throughout this legislative session. And as mentioned before, we have grave concerns about the 340B program and if there's pending cuts coming potentially from Washington, D.C. We'll have to see what happens there. So thank you, Mr. Chairman, for this opportunity, and Danny and I will be around.
Okay, good. Thank you. Questions from members? Representative Franson, go ahead, please.
Thank you, Chair Backer. So, Ms. Krinky, I was interested to hear when you're talking about the younger generation and they don't want to work as much. What about the travel portion for like travel nurses, et cetera? I know that nursing homes have a lot of issues with that, and the generation that is graduating, they want to see the world, and they're taking those opportunities.
Ms. Krinky.
Mr. Chair and members, during the pandemic, we were very reliant on travel nursing. Many nurses saw it as an opportunity to work in different places, and the salary was better. Fortunately, what has happened over the last couple years, travel salaries have actually gone down, and we have raised our salaries. So the differential between the two is better than it used to be. That's good news. Our vacancy rates in nursing has dropped. I think we're now at 12%. We were above 20%. So the situation's gotten better. The long-term challenge, quite frankly, is that we're getting older and there's going to be fewer people entering the workforce. So we're not out of the woods on workforce challenges. So.
Okay. Other questions? Well, thank you. We appreciate everybody traveling such distance. We know back in your hospitals, you are doing probably 1.1 million things, and when you get back tomorrow, you'll have 2.2 million things. So I totally appreciate that. So members, our next meeting will be Monday, January 27th from 1 to 2:45, this place at the Capitol 120. So thank you, members. There being no further business before the committee, we are adjourned. Thank you.